Hello friends, welcome to my YouTube channel Oncology for Residents. Today we are going to discuss what is arguably the most critical topic of all, imaging for oral cancer. Trust me, you will never be taught this topic. But I can't tell you how fundamental and extremely important this topic is for oncologists. The earlier you understand, the better your life will be. Before we begin, for those who are new to this channel, I am Dr. Parveen Ahlawat. I am a consultant at Rajiv Gandhi Cancer Institute and Research Center in New Delhi over 12 years, and I have been practicing and teaching oncology for more than a decade. I completed my MBBS and DMRT from CMC Vellore, did my DNB at Rajiv Gandhi Cancer Institute, pursued a fellowship at Royal Marsden Hospital in London, and I have later undergone a specialized training in cyberknife from United States. I have been evaluating MD DNB residents for over a decade, and I can tell you with absolute certainty, this topic is one of the most misunderstood topic in the residency and also for early career oncologists. When you are facing your external examiner during OSCE and VIVA or presenting your case in a multidisciplinary tumor board, this is exactly where you stumble. You memorize the NCCN guidelines, you know the landmark trials, you know everything about surgery, you know your radiation target volumes and dose prescription, but you do not know how to order imaging and how to independently evaluate the imaging. You rely entirely on radiologist typed report instead of seeing the images yourself. You lack a systematic approach to imaging. You start making arbitrary decisions. And that is when you fall into the classic clinical traps. Let me be clear right at the start. I am not a radiologist. I am not here to teach you how to dictate a standard descriptive radiology report. I am an oncologist and I am going to teach you how to use the scans to dictate the extent of tumor so that you can make critical decisions such as surgical resectability and defining radiation target volumes. Getting the image right is the foundation of everything we do in head and neck cancer. But the clinical scope of this topic is massive. Trying to teach you all about imaging of oral cavity in one single lecture will be useless. You will just get cognitive overload and retain nothing. To make this actually work for you in clinic, I have broken this topic into 4 distinct modules. Part 1, which you are watching right now, covers foundations and acquisition protocols of imaging. We are going to establish exactly which CT and MRI sequences you must demand from your radiology department so that you do not make a geographic miss. Part 2 will cover imaging for centralized tumors, specifically the oral tongue and the floor of mouth. There, we will establish that MRI is the imaging of choice. We will break down how to use its superior soft tissue contrast resolution as the absolute best tool to measure depth of innervation, assess neurovascular bundle and look for perineural innervation. Part 3 will shift to imaging for lateralized tumors such as buccal mucosa, gingiva-buccal sulcus and retromolar trigone. For these sites, we will establish CT as the best imaging modality. I will give you the evidence-based approach for detecting bone erosion, evaluating the posterior soft tissue extent and tracking perineural innervation. Finally, part 4 is dedicated entirely to imaging for cervical lymph nodes and the distant metastasis workup. Do not watch this series straight through like a passive lecture. Use it as a clinical toolkit. If you are working up a buccal mucosal cancer case, skip straight to part 3. If you are working up a tongue cancer case, go directly to part 2. Watch exactly what you need to solve the clinical problems in front of you. Let us get straight to the evidence. We will start with part 1. Let us be honest for a moment. If I ask you right now, which scan or imaging modality is best for oral cancer, what will you answer? I already know exactly what is happening in your brain. Some of you either belong to the MRI fan club. MRI fan club. You want to scream, I want MRI. Why? Because you memorized the phrase superior soft tissue resolution on page 1 of any textbook, right? Some of you belong to the bone lovers fan club. Bone lovers fan club. You want to shout CT scan. Why? Because you are terrified of missing cortical erosions. And wait, there is another group. The future politicians, the diplomats. These guys will answer with a serious, thoughtful face and say, well, sir, it depends. Listen to me very carefully. It depends is not a medical answer. It depends is a survival instinct. In an exam, if you say, sir, it depends, that means you are indirectly saying, I have absolutely no idea. Please ask me something else. That is terrible. And in the clinic, it depends is even more dangerous. It means you order the wrong scan, patient pays for the wrong scan, we lose 3 days in doing scan and getting report, and we will still don't get the information we wanted. You may be one of those residents who order a PET scan for a stage 1 tongue cancer just to be on safer side, but ends up missing the actual depth of invasion of primary tumor because you didn't order MRI. So today we are going to kill the it depends. Guessing will not be an option anymore after this lecture video. We are going to learn exactly when to order what. I am going to give you a definitive evidence-based algorithm. I have strictly followed the Mahajan et al. 2023 guidelines, a must-read guidelines on imaging for oral cancer in Indian setting. By the end of this presentation, you will not just be ordering scans, you will be making decisions on imaging based on evidence. So buckle up, let us clear the confusion once and for all. Let us start with first part. Foundation of imaging and acquisition protocols, CT and MRI. Before we dive deep into the topic, I want to spend some time in teaching you some basics and fundamentals of ordering a CT scan and MRI. I think many of you who are not beginners might be knowing it, but those who are beginners might not be knowing it well. I will show you many of you have been doing a conventional CT scan for many years, and which is not the right scan. I will show you what an ideal CT actually should be done and looks like. Very often, we just order a CT face and neck, a conventional CECT, and accept whatever images we get from radiology department. Recall, what have you been doing so far? Do you know when your radiology technician takes CT scan of your patient, what protocol does he follow? I'm sure many of them take a contrast enhanced CT scan of the head and neck region in axial slices in soft tissue window. You have been doing wrong all these years. If you really want to stage an oral cancer patient accurately, a standard resting conventional CECT scan is not good enough. You cannot just fill up a CT scan form and write CT scan of the head and neck with IV contrast and send patient to radiology department and get the scan done. You need to tell your radiology technician to particularly do 3 additional protocols while taking CT scan of a patient having oral cancer. These 3 additional protocols are extremely important. We will see them one by one. First, puffed cheek technique. You must instruct your radiology technician to take CT scan in puffed cheek technique. If you do not take CT with puffed cheek and do it in resting state, you do not see small mucosal surfaces of buccal mucosa and gingiva and RMT. If there is a small tumor from one of these subsite, you cannot pinpoint the exact location if you have not done CT scan with puffed cheek technique. The entire mucosal folds are collapsed in resting state. To tackle this problem, we need to do CT in puffed cheek technique. How to do it? We ask the patient to close their lips tightly and blow air into their cheeks without leaking air from mouth, just like how we blow up a balloon. Why do we need to do this funny maneuver? Because that trapped air in the vestibule acts as a negative contrast agent. It physically pushes the cheek mucosa away from the gums. Without this air, the cheek collapses against the gingiva and everything looks like one big mass. You may find difficult to find out where the tumor has originated from. But with the puffed cheek technique, the air opens up the vestibule very nicely and you can clearly see the mucosal margins very clearly. If there is any small tumor, you will be able to see it better and pinpoint the boundaries of tumor accurately. So this is the first protocol you will ask your radiology technician to do, even if you have not written it in your radiology request form. To give you an example, this is a CT image of patient without puffed cheek in a patient who has a small ulcer over his left buccal mucosa. A beginner can hardly see any lesion in the CT scan. However, when CT was done in puffed cheek technique, you can nicely see a small growth arising from the left buccal mucosa just short of angle of mouth. This is the importance of puff cheek technique of CT. The second protocol you must tell your radiology technician to do is to do a bone algorithm reconstruction of the CT data. Bone algorithm reconstruction of the CT data. I see residents get confused by this all the time. When we say we need both a soft tissue scan and a bone scan, residents think we are sending the patient through the machine twice. We are not. We are not giving the patient a double dose of radiation. Let me explain exactly how this works in simple terms. The patient gets their IV contrast, goes into the scanner and is scanned exactly one time. That single scan captures all the raw data of head and neck region. This raw data holds the potential to become any type of image. Because it contains all the attenuation information, the computers can use different mathematical equations, algorithm to mold that same raw data into either a smooth soft tissue image or a highly sharpened bone image. Here is a widespread systemic issue across most imaging centers and hospitals I see. Unless explicitly instructed otherwise, The vast majority of radiology technicians will only reconstruct the soft tissue algorithm by default. The standard CECT neck protocol programmed into most CT scanner defaults to a smooth soft tissue kernel with 3 mm to 5 mm slice thickness. It is designed to look at lymph nodes and gross soft tissue, not thin cortical bone. Do not assume the radiology technician knows what you need. If you just write CECT neck on your requisition slip, you will only get a soft tissue reconstruction because that is their default. See, the radiology technician are managing high volume of CT scan. Their PACS storage has limits, so they will not generate your image into any other algorithm unless you explicitly demand it in writing. If you fail to write include puffed cheek and bone algorithm reconstruction on the order, the raw data will be deleted in next 24 hours. Technicians are often instructed to avoid generating massive files that overwhelms PACS server storage unless clinically justified. So he will take CT scan in soft tissue algorithm and send images into PACS. Then when a radiologist starts seeing and reporting CT, he clicks the bone window button on his screen and thinks he's looking at true bone details. He's not. What you are seeing is bone window on soft tissue algorithm. You are not looking at true bone window. Clicking that bone window just changes the brightness and contrast on your monitor. The underlying images are still blurry. If you rely on that button, you will miss early bone erosion and understage your patient. To exactly see the bone clearly, the technician in radiology department has to do one extra thing. He has to take that original raw data of head and neck region and run it through a sharp high definition filter. This creates a completely separate set of images. This is called true bone algorithm. True bone algorithm. Can you notice the differences in these two images? This one done by you when you clicked on bone window button on soft tissue algorithm images. See, the edges are blurry. This is the real true bone window. See how sharp the bone looks here. So it is one single physical scan but two separate sets of images generated by the computer. One smooth set for soft tissue and one highly sharpened set for bone window. You have to make sure your radiology department actually creates that second set of true bone algorithm before they delete the raw data from their system. Let me enlarge these images for you to see. Pause video here and notice. These are three images. Left is the standard images acquired in soft tissue algorithm, which is used to evaluate soft tissue lesion. This is the image you get when you click the bone window on soft tissue algorithm image. That is not what we want. We want this. The true bone window algorithm image. It is acquired from the original raw data of head and neck region and running it through a sharp high definition filter. That creates a completely separate set of images. This is the true bone algorithm. Now look at the differences between these two images. This image is still blurry. You cannot see the bones so clearly. Now look at this, the true bone algorithm window. See how nicely you can see the bones and its edges. If there is any tumor causing erosion, it is unlikely to be missed in this image, but you may miss it in this image. The third additional thing you must ask your radiology technician to do is to do multiplanar reconstruction. Multiplanar reconstruction in coronal plane or parasagittal plane beyond your standard axial views. Multiplanar reconstruction. Remember, if you do not ask for it, the radiology technician will not do it because he may not know what you need. If you just write CECT neck on your requisition slip, you will only get a CT images in soft tissue windows. To catch an early tumor eating into the alveolar ridge, you must look at the coronal and sagittal planes. These are two such images in multiplanar reconstruction. This is in oblique sagittal reformation. Reformation just means using the computer to reslice the 3D block of raw data from different angles. You must look at the coronal slices. And more importantly, you need an oblique sagittal reformation. These are examples of a multiplanar reconstruction showing oblique sagittal reformation images. In this image, you can see retromolar trigone shown with dotted white line, which is the mucosal fold in the area posterior to the mandibular last molar, extending along the ascending ramus of mandible up to the maxillary last molar. If you had not done multiplanar reconstruction and looked only in standard axial, sagittal or coronal view, you wouldn't have seen it so clearly. See, this is another oblique sagittal reformation. It shows the entire extent of inferior alveolar canal as shown in dashed black arrow in the body of the mandible. It starts from the lingual side of mandibular ramus at the mandibular foramen, continues on buccal aspect of body of mandible and ends up at foramen and mental foramen adjacent to second mandibular premolar tooth. If you had not done this multiplanar reconstruction and looked only in standard axial, sagittal and coronal views, you would not have seen the entire inferior alveolar canal so beautifully, and you might miss early inferior alveolar canal nerve innervation. Remember, it is an important anatomical pathway for perineural spread of cancer on the floor of the mouth. So, the bottom line is, when you get all three additional things right, that is, you get CCT done for head and neck region, number one in puffed cheek technique, two with a true bone algorithm, and third with a multiplanar reconstruction. Only then you are ready to evaluate a malignancy and you will do really a good job in knowing the true extent of tumor. Every component is important. You must write in request form CECT head and neck and puffed cheek technique and bone algorithm and with multiplanar reconstruction. It is only then you write a complete request for CT. If you don't ask for these exact things, your radiologist technician will not do it. And your radiologist will not be able to report it well. You may miss critical information about the exact extent of tumor. It allows you to accurately see the depth of innervation, map the tumor extent, identify bone erosion and track nerve spread. So do not just order a generic conventional CT scan. Always explicitly ask for puffed cheek technique and a bone algorithm reconstruction with multiplanar reconstruction. Do not accept anything less. In some specialized centers, this protocol is incorporated in their routine work, but not in many other centers. This is an ideal CT protocol you must follow in your radiology department for any patient with oral cancer. I hope I made it absolute clear to you how to acquire an ideal CT scan for head and neck malignancy. These are some important things oncologists are not taught, so I thought I should teach you at the beginning of your career in oncology. Let us talk about another modality, MRI scan. These are the necessary MRI sequences we must acquire for any case of oral cancer or head and neck cancer. This slide is going to be very heavy for you. There is a lot of information in it. I can't tell you how important it is for you. And I'm going to spend a lot of time explaining this slide. It is my request to you that watch this slide only if you are in good mood to grasp. Otherwise, skip 5 minutes video and continue watching. Let's start. See, because getting the imaging right is the foundation for everything we do in oncology, if you start with a bad scan or misinterpret the sequences, you will understage the patient, compromise your target volume, and ultimately fail treatment. As oncology resident, you do not have to read these scans like a radiologist, but you absolutely must know what each sequence is built to do. This way you will be able to evaluate MRI independently to some extent. You will be able to take some decisions based on your reading of MRI of your patient. If you look at the wrong sequence for the wrong anatomical problem, you will stage the patient incorrectly. These are 4 sequences of MRI you need for head and neck cancer. Here is the exact clinical breakdown of the 4 sequences on your monitor and exactly how you will use them. For beginners, I will tell how to find which sequences is which. Look 2 things in each sequence: CSF color and fat color. In T1 pre-contrast, CSF is dark, fat is bright. This is your sequence which shows the anatomy well. It shows muscles and fat spaces well. So this sequence shows the baseline anatomy and fat planes. You use this sequence for one primary reason: to evaluate bone marrow of the mandible and maxilla. Normal bone marrow is filled with fat, so it naturally appears bright on T1 pre-contrast. When an oral cavity tumor invades bone marrow inside the bone, that bright fat is replaced by a dark hypointense tumor signal. It thus upstages your patient to T4A. Next sequence, T2 weighted. Here CSF is bright and fat is also bright. So this is your baseline anatomical map. It is excellent for evaluating overall tissue architecture, edema, fluid-filled cystic spaces. However, it has a major limitation in oral cavity. Because the surrounding fat remains bright on standard T2, it completely lacks the necessary contrast to accurately delineate the primary tumor margins. You cannot accurately stage the primary tumor with this sequence alone. You must use fat suppression. Next, T1 post-contrast fat suppressed sequence. Here, CSF is dark, fat is also dark. This is your workhorse sequence for neck. workhorse sequence for neck. It does two important jobs. One, once intravenous contrast is administered and the fat signal is suppressed, this becomes your mandatory sequence for staging the cervical lymph node. It sharply differentiates a viable enhancing metastatic node from a node with central necrosis. It is also your absolute gold standard for tracking perineural spread. If a cranial nerve like 5th, 7th or 12th is involved, it will starkly enhance against the dark suppressed fat of the skull base foramina. However, remember a pitfall with this sequence. You must never use this sequence to measure depth of invasion in the tongue cancer. The gadolinium contrast makes both the tumor and the reactive normal surrounding muscle enhance simultaneously. The borders will blur and you will definitely overstage the primary tumor. Next, T2 weighted stir sequence. Here CSF is bright and fat is dark. This is your master sequence for primary tumor. When you need to evaluate the primary tongue tumor and calculate the precise depth of invasion, this is strictly the only sequence you should rely on. Squamous cell carcinoma is highly cellular and appears bright, while the dense intrinsic muscles of the tongue appear profoundly dark. This creates a razor sharp measurable boundary between the cancer and the normal tissue. Furthermore, stir sequence mitigates the magnetic susceptibility artifacts caused by dental amalgams. Standard chemical fat saturated images are routinely destroyed by these dental artifacts, but stir remains robust. You need to know one more sequence of MRI. It is called DWI, diffusion weighted imaging, and ADC, apparent diffusion coefficient map. So DWI, ADC. We have already discussed T1, T2 fat sat, stir and post contrast sequence. Those sequences show anatomy and enhancement. Diffusion weighted imaging and ADC add something different. They tell you about the function. They tell you about tumor cellularity and how freely water is moving inside tissue. That matters because in oral cancer, the main confusion on MRI is often, is this a true tumor or is this edema or inflammation or post biopsy change? So what is DWI? Diffusion weighted imaging. It is not a tumor sequence. It is a water motion sequence. In highly cellular tissues like most cancers, cells are packed tightly. Water molecules cannot move freely. Hence, it is called restricted diffusion. On DWI, restricted diffusion commonly appears bright. On DWI, restricted diffusion commonly appears bright. But here is the trap. DWI can look bright for two another reasons. Number one, true restrictions, that is highly cellular tumor, or T2 shine through. Here, the region looks bright because it is already bright on T2 because of edema or inflammation. So DWI alone is not reliable. You need something more. You need ADC map, apparent diffusion coefficient map. It is a calculated map that quantifies diffusion. When there is low ADC, that means water movement is low. This is called true restriction. Where do you see it? In cancer. When there is high ADC, that means water movement is free. There is no restriction. Where do you get it? Inflammation or edema. That is why we need ADC. It tells you whether the DWI brightness is real or fake. Why do we need DWI ADC when we already have other sequences? Because T2 fat saturated and stir sequences and post contrast sequences can overestimate tumor. In T2 fat sat stir, tumor and edema can both look bright. In post contrast, tumor and inflammation can both enhance. DWI ADC helps you here. Is this tissue behaving like a high cellular tumor or not? Clinically, this helps in number 1, distinguishing tumor from surrounding inflammatory changes, post biopsy or post treatment scans, supporting nodal metastasis assessment, and 4th, detecting small primaries when anatomy is confusing. Now let us understand it with an example. Look at these two images. There is a lesion in the right lateral border of tongue. How to read this slide? Step 1. Look at DWI on your left. The bright region is suspicious. At this stage, you should say only this could be tumor or because of either inflammation or edema. So how do we differentiate? Look at ADC map. Now we decide if it is true restriction. The lesion shows low ADC, looks dark. That means it is true restriction, so it is a cancer. The surrounding tissues shows high ADC, looks bright. That means there is no restriction. So it is likely inflammation or edema, but not cancer. So rule to drill into your head is DWI points to the area, ADC tells you whether to believe it or not. Or even simpler, high DWI plus low ADC is equal to true restriction is equal to tumor likely. High DWI plus high ADC means not restriction. That means it is likely edema or inflammation. Master these MRI distinct sequences. Your target volume delineation and surgical planning depend entirely on knowing which sequences to trust. I think this much is sufficient for you to know at this stage. I strongly suggest you to take a color printout of this slide and paste it in front of your contouring station for easy access. Or at least keep a screenshot of the slide in your mobile. You need to look at it again and again, and gradually you will be pro in reading MRI for head and neck cancer. So with this, we have understood how an ideal CT and MRI protocol to be followed. I really took your time to explain this because I feel these are fundamentals for head and neck oncology. Now let's move to our original question. Imagine you get an oral cancer case in your exam and your examiner asks you which local imaging modality will you order for this patient with oral cancer. Suppose you get one of these patients. This is a tongue cancer. He has upper gingiva, he has hard palate, he has lower gingiva buccal complex cancer. Now we have three choices. Either you choose CCT or MRI or PET CT. Which imaging will you choose for your patient? Most residents will just pick their own favorite modality or pick up something their bosses have been doing for their patient. I had noticed that many residents say MRI for every case of oral cancer they get in exam. I think I know why they say so. Because unlike CT scan, MRI has many shades of white, grey and black. It looks very beautiful and attractive to you looking at MRI. The second most common imaging I have heard from residents is PET-CT, because they see a tumor lighting up like a bright yellow light bulb. Also, residents often think PET-CT is one-stop solution for everything, for primary, for neck and for distant metastasis. I hardly hear residents saying CT. I hardly hear residents saying CT. This is not expected from oncologists. Let us decode in next video which imaging to be done for which patient. Stop answering a imaging randomly. Trust me, if you just pick one scan for all patients of oral cancer, you are going to be wrong half the time. Getting my point? So, how should we choose the best imaging for a particular patient? The correct answer is, sir, before I select the best imaging for my patient, I want to look at two specific parameters. Number one, what is the primary site of tumor of my patient? Whether it is a central disease in the oral cavity, that means tongue and floor of mouth, or is it a lateral tumor, also called as vestibular space tumor, such as buccal mucosa, gingiva-buccal sulcus or RMT. Second parameter, what are you suspecting? Are you suspecting bone involvement? That will change your T stage and change your surgical plan. Or are you worried whether a nerve is involved? When a patient says he feels numbness or paresthesia over some part of his face. If you ignore these two questions and order a scan randomly, CT or MRI or PET, you are just guessing. And we don't guess in oncology. Simple as that. Clear? So let us dive deep into the first factor which will decide the imaging modality we will choose. What is the site of primary tumor? In my next video. Stay tuned. The real work begins in the next 3 sets of video. In next video, we will talk about the imaging for oral tongue cancer. Signing off, Parveen Ahlawat.